Hi everyone, welcome back to Forward Therapy. First and foremost, Happy New Year. It is 2025. I know I've taken a little time away and I want to thank you for allowing me to do that, to spend the holidays with some downtime, enjoying time with my friends and family, and just honestly just taking a break, decompressing. My name is Kelly. I am a certified hand therapist and we're back with a bang. I have had so many comments over the last few years. Whenever I ask my subscribers or Instagram followers what you are interested in seeing, there's always a few comments that are like tendon repairs, flexor tendon repairs, protocols for tendon repairs. And I know that I have put this off for so long because honestly, I was terrified to go over this because I just didn't feel like I had a lot to share that was valuable. And to be quite honest, tendon repairs are terrifying. I don't know if you guys feel that way too, hand therapists out there. I do not feel terrified by them at this stage in my career, which is awesome. Most of the time. Okay, some of my patients definitely like to scare me if they come in without their splints and telling me that they're doing all these crazy things. But overall, I will say that I feel fairly confident. I definitely don't get quite as like sweaty and nervous when I see that on my schedule. So I want to do a series about it. So I finally want to give you guys what you want. And thank you for waiting for so long for me to develop self-confidence and to feel like I had something to give, to share. So that's what we're talking about today. I think I'm going to do this series of videos kind of in a series because I just think it's too much to cover in one video, and I think there's so much information to go over. And when you are a hand therapist, or especially like a newer therapist or a newer grad or somebody that's kind of new in the hand therapy realm, or if you worked in a clinic where you didn't have tons of post-op cases, which is true for me. For my first 4 years of practice, I maybe saw 1 or 2 tendon repairs in 4 years. And in the last 4 years of my career, I have no idea how many. It's so many. Not that that's like the primary thing that I treat, but we get several a month, or several in a few months even. So yeah, it's something that I've definitely gotten a lot more confident with because I've had more practice at, and so I'm excited to share that with all of you. So thank you for sticking with me through this terribly rambly introduction. I think today's video, I want to start by just starting with the basics. How do you complete a flexor tendon evaluation? Initial evaluation. Your patient's coming in, you see them on their on your chart, the sweat starts to come up, you start to feel the butterflies in your stomach, you start to get like just kind of that like panicky feeling. Totally been there. We'll probably be there again, but this video is for you, so let's get into it. I should preface this by saying my way is not the only way. I'm just going to share with you what I know that I like to do and how I approach a flexor tendon initial evaluation. Yeah, just take that with what you will and know that I am going to share how I approach it, and hopefully it is helpful to some of you, if not everybody. My initial approach, what I firmly believe is that your flexor tendon evaluation begins before the patient ever arrives to the clinic, okay? Before your patient arrives, you should have already started your chart review process. You should have, ideally, in an ideal world, right, the op notes, the op report, hopefully maybe some doctor's notes, if the patient has been seen by the doctor, which they might not have because ideally we're seeing them 3 to 5 days after surgery in most cases. You should have an idea of either what the surgeon that is referring to you prefers as a protocol, or any precautions or kind of complications that they experience, or things that they are sort of cautious over. So for instance, in my case, I work in a large hospital system, which is really nice because we have all of our patients' charts in one place. So I am really lucky, and I know that not everyone has access to that. But I have, the op reports, I have any doctor's notes from pre-op, I have any doctor's messages from, post-op, anything that they may have given them. The doctors will typically, the ones that I work with, are usually really, really good about putting at least some sort of guidance, whether they want this patient to be like immobilized for 3 weeks and delayed motion or passive motion only, or if they want us to start some early active, if there were any complications that we need to know about or any preferences they have about the splint. Sometimes we get a lot of information. Sometimes we get a referral that just says passive motion okay. So there's a lot of leeway there, but I'm also very lucky in that our health system has a really convenient emailing function and a chart chat function, and so we can easily sort of instant message surgeons. They might not respond right away, or we can send them a staff message like an email, and the surgeons I work with are luckily really, really responsive, and so I do think that is helpful. If you have any concerns or questions, if your referral, it has no information on it, you don't know the zone of injury, you don't know anything about the patient, anything about the repair, especially things like, is it a 4-strand, a 2-strand, a 6-strand, did they do an epitendinous stitch, did they do a Lance under, wide awake, like there's so many things that are really important to know, right, for us as therapists. So I do recommend, if there's any way possible, to get in touch with the surgeon if you have any concerns or questions, or if it's a surgeon you're not familiar with and you don't know what their preferred protocol is, try and get in touch as best you can. I know we can't always. I've experienced that in the past too, where I just couldn't get in touch with the doctors, or I just didn't have time. But do the best that you can. I do advocate for, especially newer therapists, look ahead in your schedule, for a week. Check what's coming up in your schedule the next few days. That way, if you see something coming up on your schedule, you have a chance to review the notes, maybe ask for help getting some additional notes sent over from the clinic or notes from the surgeon, or maybe having time to have a phone call with the surgeon or an email or something like that. So that's my tip number 1. The eval starts before the patient comes. You should have that information ready so that you feel confident to choose what the next pathway is. Oh, I have to show you. I'm representing occupational therapy. I think this sticker is so cute. My next tip is to choose your protocol. So all of the information that you got from the doctor or from the referring notes or anything that you've collected, try to have an idea of what protocol you want to follow. Sometimes the patient gets there and you can tell that they are not going to be really compliant, or they have something that you didn't know of, like maybe a cognitive deficit that you just don't really trust them to follow your instructions perfectly, or children, right, like younger kids, sometimes need to follow a different protocol because they might not be able to follow what you're asking them to do perfectly. So do the best you can, be ready for, what happens if the worst case scenario happens. But generally when I'm thinking about choosing a protocol, I personally like to combine protocols a lot. So I know that's not like the perfect response that somebody wants to like meticulously look at, which is how I felt when I was first getting started in practice. I just wanted somebody to hand me a list and say, okay, it's either X, Y, or Z, and you follow those perfectly. But honestly, it ends up being kind of a combination of things a lot of the time. So I'm sorry. I know that's not the most helpful. But in my brain, I'm starting to think, okay, am I going to do delayed motion, so like early passive motion with people? Or am I going to go more towards like an early active motion protocol? And so that first decision on that decision tree is going to really help you figure out, where am I going next with this? What kind of splint am I going to do? What kind of exercises am I going to give? How is the progression going to look? Because those two are going to look very different. So that's like your second, step, is like pick the protocol, or kind of have an idea of which way you're leaning. Is it more of a passive motion, like early passive, delayed motion, or is it early active? After you've sort of decided on a protocol, prep as much as you can in advance. I don't know about where you work. In my clinic, a lot of times our flexor tendon protocols, sometimes we're lucky and we get them booked in our 1 60-minute appointment a week, but it doesn't always work out that way. So an initial appointment might be 40 minutes and the patient might be 5 to 10 minutes late or even more sometimes, which is, is what it is. You can't control it. But we generally need to get things done quickly and get them on their way so that they are safe, they have a splint, and they have some exercises to work on, right? The whole point of getting them in early is that we get movement early. So we're starting to help control edema. That's a really important one. We're starting to help do some sort of joint motion. So it is really helpful if you can prep as much as possible in advance. I personally like to cut out a dorsal blocking splint in advance. We have 2 patterns in our clinic that are just sort of general dorsal blocking splints. I always have to make adjustments to them because nobody is fit to that like model size. But I think it's really helpful just to have the base cut out so that the patient doesn't have to sit there and watch me like hulking through the plastic. It just saves me like 3 minutes of cutting, right? And that adds up. I also like to cut all my hook Velcros beforehand. So I think to myself, okay, I'm going to need 2 at the wrist. I'm going to need, 2 at the proximal phalanx. I'm going to need 2 at the middle phalanx kind of ish generally. And then I'm going to need 2 at the forearm. So I cut all my hook strapping out beforehand so that when I'm making the splint, I just have to peel it, heat it, and stick it. And I don't have to fiddle with like cutting all this Velcro the whole time. So I like to prep everything in advance, make sure your surfaces are clean, make sure that you have like the stuff to cut off post-op bandages and dressings and all that kind of stuff. Maybe having a towel laid down if you want to do that, just for comfort for the patient or just to keep your work area clean. So prep as much as you can in advance before the patient comes into the room so that you have a few minutes that are saved, basically. It just helps you be more efficient, in my opinion. Okay, next step. Patient is in the room, they've sat down, you've introduced yourself and what we're going to do. The patient's doing just, fine overall, or however they're doing, if they're having lots of pain, whatever. First step is they're probably in a huge bulky bandage, right? We need to get that off of them. So before you even go near their hand, touch their hand, anything, you're going to clean your hands really, really well. Make it really obvious that you're doing like very good hand washing skills. Dry them off, put on, fresh pair of gloves. Then you can get into work. You can take off their post-op dressings, their bandages, that huge plaster, bulky wrapping, all that stuff that they have on. And check out what their wound looks like. Look at the stitches, appreciate the wound, check to see if there's any signs of infection, dehiscence, like anything that just looks wrong. You want to also observe kind of their, edema. If they look super swollen, that makes you kind of change your mind about if you're going to do early active that day or if you're going to delay and just start with passive movement and focus on edema management. All those things are really important. And the reason why I say edema management is so important, in that first 3 to 5 days, most people's edema, like the initial post-op edema, is starting to come down a little bit more. But some people, it just hangs on to them for dear life. Either they haven't been elevating enough or it's just, they just tend to retain more fluid in that area. And any increase in edema is going to significantly increase the drag or the force on the tendon. We don't really want that with active movement with a tendon that's going to start weakening within a few days, right, after the surgery. So I always look at edema. If they are really, really swollen, really edematous, I'm going to know that I need to focus on a lot of let's see if the patient can clean their other hand and do maybe like some really gentle lymphatic drainage, or I like to use 2-inch Coban, make a tube around their finger and then pinch the edges so that they can just slide it on and off. That way they don't have to fiddle with wrapping the 1-inch, which is very hard to do without them accidentally moving their finger too much. Or maybe you're going to think about, giving them like a digi-sleeve if you have something like that in your clinic, any of that kind of stuff, or, whatever you want to try to do for edema. So it just helps you start to formulate, okay, this is going to be something I really need to go over with this patient and make sure is in their home program. So those are all, really good things to be observing and paying attention to as you're unwrapping them. The other thing that I always like to do while I'm taking everything off of them is let them know, okay, you had the surgery, your tendon is now sewn back together, and our primary goal in the next few weeks is to protect this healing structure. So really, really important things to avoid are opening your hand or having your hand get pushed open. We need to keep it in this protected shell position that the splint will put you in. And then I also want you to avoid actively making a fist or kind of gripping or using the hand. Because both of those movements are going to cause too much stress to that tendon, and it's going to cause it to weaken, pull apart, or possibly tear again. And then you might have to have another surgery. So I always make sure the patient really knows, okay, here's what I don't want you to do when I take this off you. I want you to stay in this position as best you can. Just continue to emphasize that throughout the entire evaluation. Next step is making the orthosis, right? And I like to, because again, we are limited on time. While I am making the orthosis, while I'm heating the thermoplastic, while I'm molding it on them, I'm educating them the entire time. Reviewing the precautions, we're going over the positions to avoid again, we're talking about, any questions that they have, but especially hitting those precautions multiple times. They can't hear it enough, really. And, you'll be able to find some people that they'll take those precautions really, really to heart and almost too much. So you want to be careful not to scare them. And then there's some people that will take those precautions and just not pay attention to them at all. So you want to scare those people like a little bit. And over time, you will start to recognize kind of which personalities are going to be on either side of that spectrum and who you might need to be extra strict with and who you might need to be like, nah, it's okay. You're not that fragile. So those are all things, nuances that you'll learn over time as you see more patients and get more exposure to this. I have found also that when you're making this orthosis, right, because if you're making, it depends on what splint you're making. Okay, I'm just going under the assumption of the most common splint that I make, which is a dorsal blocking splint, static. I have never done a dynamic flexor tendon splint. My surgeons don't typically ask for that, or they haven't yet. So, we'll come to that when the time comes. I don't fiddle with any of the hinged braces, like the Kleinert stuff. No, simple dorsal blocking splint. Get them the good mold. I do put them in neutral to slight wrist extension, right? Because we've come from the idea that wrist flexion is the best position to knowing that puts more stress on the tendons. It's harder for us to move the fingers. So we want to position them most of the time, again, all surgeon dependent and patient dependent, but in slight extension. And then the MPs, again, I don't position them down that far, maybe 30 to 50 degrees, depending on, again, what position they came in into the clinic with their post-op splint, or if the surgeons told me anything specific. But again, if we have our MPs flexed too far, it's going to be very hard for them to make a fist, because we know we start the movement of making a fist with kind of that claw movement. And so it's just going to put more stress on the tendon than it needs. My pro tip for the position of molding, if you have one of those foam ramps, hopefully you know the ones that I'm talking about, where you can have the patient rest their hand up. If you rest them on top of that, and so that they're kind of over the edge and their fingers sort of sit in that little bit of a curve, it's a lot easier than trying to have them in this position and then they're trying to help you and move all around. So that's just my pro tip that I found to be helpful. So you make your splint, you get all the straps on. I often, especially if it's the small finger, which is almost always the small finger, it's the devil's finger. If you know, you know. Because that guy's so short, a lot of times when you do the straps, it can be challenging to get it in a fully extended PIP position, and then we end up with like a joint contracture, and then it's like months of therapy that's just super complicated and annoying for the patient and for the therapist, to be honest. So if you use a 2-inch, like a neoprene strap, if possible, if you have that kind of adhesive, a little bit of stretch strap, and you fasten that around the middle of the fingers, like kind of the second strap towards the tips, it seems to help a lot more than like a 1-inch strap. But just trying to encourage that PIP into a little bit of extension in the splint is really helpful so that you can avoid those nasty joint contractures. Sorry, I know I'm rambling a ton, but I'm just trying to give you as many tips as possible. After the splint is complete, thank God, we've made it through that part at least, right? I always breathe a big sigh of relief when the splinting part is done. And yeah, if you know, you know. Slaving over a hot splint pan while you're nervous is like not really the most fun thing in the world. But now the splint is complete. You've gone over their precautions probably a few times. You know, you should definitely document that you've did that and that the patient verbalizes agreement to the precautions. Now it's time to give them exercises. And there's a lot of variations in exercise that you can give them. I, again, am not going to really go into like exact specifics because it's going to depend on which protocol, general idea that you're following, or guideline, I should say, which guideline you're using. If it's delayed motion versus early active motion, they're both going to look a little different. I would recommend for the first visit giving them 3 exercises, somewhere in that realm. If you can limit it to 3 or 4 is fine. You can give them more if you want to. I just find that it's so overwhelming for people, for these patients. They just came out of surgery a couple days ago. They're still on like pain meds probably. They're like out of it. They're loopy. They're overwhelmed. And you're asking them to do something multiple times a day. And it's kind of a scary thing. It's like a scary injury to have for them. And so I think they will better succeed and they will better feel like they're confident about their exercises if you limit it to 3 to 4. So that's my pro tip there. I think just 3 or 4 at first. You can always add on to it as they get more confident and comfortable. I always demonstrate it on their uninjured side. Like if I'm having them do, you know, passive movement, or if I'm having them do active movement, do it on their unaffected side first so that their brain recognizes what that feels like and how much force it takes. And then they can do it on their other side, or, you know, then maybe I'll do it on their uninjured side if it's passive. Their injured side. The affected limb, if it's passive movement, I'll do that on that side so that they can feel kind of how much force I'm using, and then I'll have them do it as well. So it's sort of that 3-step process. Do it on the unaffected side so they can feel, do it on their affected side, and then the patient does it on their affected side. There's lots of different opinions, I think, on how many times a day. And I'm not convinced that there's a right or a wrong answer here. I think it needs to be very frequent. I think it needs to be not 3 times a day for 10 reps. I definitely don't think that's anywhere near enough because we need these people moving a lot. I also don't think that once an hour is always the best choice, because I think it's really hard for patients to adhere to that because they're tired. Even though they're home, they're like probably not doing anything. When you're after surgery, the day just like goes by somehow. It's a very weird time warped feeling, but I just don't think they're going to get it in that often. And I also think, you know, a lot of times, for a long time I did this. I said every hour, 10 repetitions of each exercise. I don't think that volume is enough each time, and I think they don't get enough repetitions in throughout the day. So what I've started to shift to in my practice, which is something that actually I heard in a presentation by Jinbo Tang recently, and it's really changed my practice in the last year or so, is that I tend to recommend patients, you know, strongly recommend 4 to 6 times a day, that they carve out a period of time that's about 10 to 15 minutes, and they set a timer on their phone and they hit the timer and they do their exercises for those 10 to 15 minutes. You know, an easy way to do it is if you have 3 exercises, set a timer for 15 minutes. Every 5 minutes, you switch to the next exercise. That way, I think they're getting a little bit more volume in with the movement. They're getting more comfortable with it. It's not as like scary each time they go to do it. They start to feel more confidence with what they're doing. I think they're getting a little bit better activation if they're doing active movement, or we're just flooding that area with blood and movement. And I think for me that seems like it's been more helpful. So I would love to hear about what you guys do and what your opinions are on that, and what your recommendations are too, or what you found that has worked well for you. Because I know that we all have kind of different preferences and different people we've learned from. So it's just nice to hear kind of what everyone else is doing too. And then my last tip is to give them something to walk out the door with, whether that is virtual, online, right? Like if you have home programs that you can send virtually through their messaging system, which is something that we have at our clinic, the availability to do. It's also nice because most people have a phone with them all the time. So if they want to just film the exercise program and then, film you talking, that's great if you're all comfortable with that and that patient feels like that's going to work well for them. I also like to usually print out a copy of the Indiana protocols. They have this really nice, in their newest version, like a patient handbook that goes through patient education. And so they have like all these handouts that are really nice, and they have some good ones for flexor tendon that list all of the like precautions on the back side. So even if you, kind of change the exercises a little bit, at least you have something written in words, in print, that you've handed to them that has their list of no-nos, right? So I think that's really important. I always document if I've given that to them and just to protect myself, but also to, let the doctor know that if anything happens, like we did go over this. And also I think it's helpful for the patient because, again, a lot of it goes in one ear and out the other when they're with us. So that's my last tip, is just give them something that they can take home, whether it's virtual or paper or on their phone. I think this was probably the longest video ever, and I can't wait to edit it, and I'm so sorry in advance, but I hope that it was helpful. If you made it all the way through here, you are amazing. You're a rock star. Let me know if you made it. You can just maybe write in the comments like flexor tendons, yay, or something, whatever you like. And I hope that this video is helpful. Let me know what other videos you'd like to see. Again, I'm going to make a series of these flexor tendon videos, and we'll see kind of how that goes. And feel free to like the video if you enjoyed it, subscribe to the channel so you don't miss any hand therapy videos, and I look forward to seeing you in the next one.